Hello friends, this is a case of cholecystectomy, appendectomy and ovarian drilling. We are introducing varus needle through the inferior crease of umbilicus. A stab wound is given and this is a thin patient, she is not a very obese patient. So, we will introduce the varus needle and this is the 2 click and we are inside the abdomen. After that, just as usual irrigation test, suction test and hanging drop test. We can see this ball is floating in the disposable varus needle and now this ball will sink. So, that means we are inside the abdomen and now insufflation is started. So, we can see slowly 1 liter per minute gas is introduced and pneumoperitoneum is completed. Approximately 3 liter gas is used in this abdomen to insufflate the abdomen, and after that we will enlarge this incision to 11 mm to introduce the first port. Just you can stretch up to the rectus with a mosquito forceps. And now this is optical port which will be introduced through the inferior crease of umbilicus. So, it is in, hissing sound will be heard, trocar is introduced, cannula is attached with the insufflator again and then we will put the optical port. Telescope is introduced. And patient head is going up and now this is epigastric port. This is also 10 mm. And this is introduced under vision. Now, third port is introduced. This is mid-clavicular line just below the costal margin, or you can see just below the fundus of the gallbladder. This is 5 mm and you or your assistant can put this port. This will be your left hand. Now, the fourth port is 7.5 centimeter lateral and 7.5 centimeter below, almost at the level of umbilicus in anterior axillary line. This port will be used for fundus grasper and now fundus is left and it is pushed towards the right shoulder. Now, first step is adhesiolysis. These are just flimsy adhesion which will be separated. We are using harmonic scalpel to just separate and strip it down. And these adhesions are separated. At that level we have the roviate sulcus, so that will be visualized, and then Hartmann pouch is given anteromedial traction and this is the posterior peritoneum which is separated up to the 1/3 of the gallbladder. Now, this is anterolateral traction and anterior peritoneum is separating only peritoneum as near as possible to the liver so that it will help us to make the posterior window. Now, little bit peritoneum over the cystic pedicle will also be separated, that is skeletonization of the cystic pedicle. Below is the cystic plate and these peritoneum will separate, so that we can make the anterior and posterior window by Maryland. We can see this is CBD and this is ICG mode. We can see ICG mode is showing the CBD and this is cystic duct. This is contrast mode, ENV mode. Different modes are there in the camera, that is 1788 camera. And this is cystic duct. Now, this Maryland will be introduced to make the posterior window, and it is in between the liver and the cystic artery. After that, this is the anterior window. You can separate the artery from the duct by Maryland. And here is the anterior window in between the artery and duct. These are fibrous trabecules which you can separate to skeletonize properly the artery and duct. This is important that when you make this window, you should take care that vibrating jaw of the harmonic should not directly touch the this artery on the duct, and this is the anterior window. Little bit more enlargement of the posterior window can be performed, so that you can see the properly both the windows. And now this is the anterior window. After that, you can turn the ICG mode again to just confirm that this calots and critical view of the safety can be find out. So, this is again ICG mode. You can clearly see the CBDs and this is cystic duct, and above we can see common hepatic duct is also visible. This is the cystic duct, this is CBD, this is common hepatic duct, and if you will put the telescope little in, then right and left hepatic duct is also visible. Now, this is clipping the artery with the titanium clip. Both the tip of the clip applicator must be clearly visible, and then you can clip the artery. After that duct is clipped, take care that do not go very near to the CBD, little at least 3 millimeter we should leave away from the CBD, so that lateral clipping of the CBD should not happen. So, this is the first clip. After that, we will apply the third clip, that is 9 millimeter away from the first one, and then second clip 3 millimeter away from the first one. Here we will use harmonic to cut the cystic duct and cystic artery. This is second clip over the artery, and now this harmonic will cut the artery first. You should keep it relaxed when you are cutting the artery, so that minimum of the harmonic will do the proper sealing. At that time a lot of traction should be avoided. And now this is the duct which is cut. Again little relaxation is good so that it will seal. Now we can again hold the Hartmann pouch with the left hand, and then anteromedial anterolateral traction will be given, and a good areolar plane should be achieved, and slowly gallbladder will be separated from the liver. Sometime blunt dissection also is good to make a good areolar plane of dissection. Traction will be optimized to hold with the left hand more nearer to the liver, so that proper anteromedial and anterolateral traction can be given to separate the gallbladder from the liver. After cholecystectomy, here we will perform the ovarian drilling also, because this patient has polycystic ovarian disease, and previous episodes of appendicitis was also described by the patient. So, she has opted for appendectomy also. She wants that we should remove appendix also. So, although clomiphene citrate has been given for ovarian drilling before, but she want ovarian drilling also because of the polycystic ovarian syndrome. So, now the fundus grasper has been removed, and then we will optimize the traction by holding the gallbladder little more nearer to the liver, so that a good areolar plane should be achieved. Generally, we keep the Teflon jaw of harmonic towards the gallbladder so that it should not puncture. Sometime blunt dissection also can give you a good plane, and you can separate keeping a areolar tissue in the plane. Now it is almost over, but before cutting the last part, we will have final view, and just light cable is kept up at 12 o'clock position, and again ICG mode is done. You can see cystic duct is clipped and CBD is nicely visible. There is no any duct of Lasca or cystohepatic duct, and there is no any bleeding, and it is dry. After that, again you can switch off the ICG mode, and then final cut will be given to separate the gallbladder from the liver. So, this is over. After that, we can bring a claw forceps from the epigastric port, and then gallbladder will be pulled out. Here we are not using endo bag to remove gallbladder because it was hidden into the cannula and then taken out. After that, here we are putting the telescope to the epigastric port and one grasper in the umbilical port. and these all mesentery and a small bowel will moved up. Here is sacral promontory, you can see, this is sacral promontory, and here we can see this is sacral promontory, this is median sacral vessel which is visible. Here is the internal iliac, this is common iliac, this is ureter, and just below the ureter internal iliac is pulsating, and above the ureter external iliac is visible. Peristalsis of ureter also you can see, this is IP ligament, this is ovary, this is right ovary, uterus is retroverted little bit, and this is left ovary. Now from anterior axillary line port we will put one grasper that will hold the ovarian ligament. And from umbilical port we are putting the PCOD needle, and we will just puncture at the 4 pole of the ovary. Fimbria is visible as you can see on the left side, and this is puncturing with the PCOD needle, so that there will be no any chances of the burn and no adhesion. So only 4 pole we will puncture. Take care that this PCOD needle should not touch the tube. So this is the third puncture, and now one more 4 puncture will be given, and it is over. After that, this is the right ovary. Again ovarian ligament, you should not hold the tube, and then this is punctured. You can see this is a small follicular cyst which is developing, and fluid is leaking out after puncturing, and this is also 4 pole is punctured. So this is finished. After that we will do little irrigation and suction, and little fluid also we will leave it inside, so that any adhesion should not develop. For the anatomy, we can see these all activities done by umbilical port, and for the same port which we have done cholecystectomy, we will perform the other surgery. So no extra port is used. Now this is median umbilical ligament, that is obliterated urachus. This is median umbilical ligament, obliterated urachus. This all is bladder in front, and these are the 2 medial umbilical ligament. This is the median, and these are the 2 medial umbilical ligament. This is one medial, and bladder is in between 2 medial umbilical ligament. This is bladder. That is why in hernia surgery also you should never sharply cut medial to medial umbilical ligament, because this area belongs to bladder. So this direct hernia, if it will be there, it will be here, and indirect will be lateral to inferior epigastric vessel. Now this is inferior epigastric vessel, that is lateral umbilical ligament of right side. This is inferior epigastric vessel, and this is inferior epigastric vessel of the left side. This one is also called lateral umbilical ligament, that is inferior epigastric vessel. This is inferior epigastric vessel of right side. Here will be the Cooper ligament. This is the inguinal ligament landmark which is going, but inguinal ligament won't be visible by laparoscopy. Here should be the Cooper ligament, that is called lighthouse, and when you reflect the peritoneum medially during hernia, you can see that. This is the deep ring, this is the round ligament going, this is round ligament, and this is triangle of Doom. Here psoas muscle, and these are the external iliac artery and vein which is visible over the psoas. Here is the triangle of pain where LFCN and GFN will be there. This is deep ring, and this is the triangle of pain. The external iliac artery and external iliac vein. Vein will be medial, artery will be lateral. This is sitting over the psoas muscle, and this is the psoas muscle, and just lateral to that will be GFN and LFCN, lateral femoral cutaneous nerve of thigh, and genital branch of genitofemoral nerve. Sometime nerve is visible through the peritoneum. Once you will move the peritoneum, you can see LFCN, lateral femoral cutaneous nerve of thigh. So, this is the round ligament, this is the external iliac artery and vein, and here is the IP ligament, and this is ureter. You can see peristalsis of ureter, and just below the ureter is the internal iliac. This is internal iliac, and this is sacral promontory. So, anterior longitudinal ligament, this is internal iliac, and here is the ureter. And here will be bifurcation of external iliac with the internal iliac, and aorta is approximately 5 centimeter above the bifurcation, the sacral promontory. Here we are holding it, the appendix, and this is held by the right hypochondric port, and with the umbilical port we are using harmonic to just separate the mesoappendix. So, you do not need any extra port. The surgeon has to move near the shoulder, and this is slowly separating the mesoappendix from appendix. At that time, anteromedial traction will be given by the assistant, and you can separate laterally. Sometime little lateral mobilization is also required. So, at that time you have to give anteromedial traction over the appendix, and then you can open the peritoneal fold so that you can reach up to the base of the appendix. Right now telescope is in epigastric port, and the light cable should be at 9 o'clock position, so that you can see laterally, and then vision behind the appendix will be clear. So, this lateral mobilization is performed, and after that we will tie the knot. So, here we are using the extracorporeal Mishra's knot will be used. And now this grasper is inside the loop, and you can catch the appendix and then negotiate this loop inside the appendix. After that, slowly we should make the loop smaller, and tip of this knot pusher should be kept as near as to the base of the appendix, so that there will be no incomplete appendectomy, and then you can tie the knot at the base of the appendix. So, this is done. Now, harmonic will be introduced from the umbilical port, and then you can cut the suture with the harmonic, and after that you can cut the appendix at least 3 to 5 millimeter away from the knot, and care should be taken that this suture should not be cut accidentally with the harmonic. Distally you do not have to tie the knot because it will be sealed by the harmonic. And this is done. After that, a claw forceps will be introduced from the umbilical port, which is 10 mm, and care should be taken here. Transverse arrest of the appendix should not happen. So, we should hold it longitudinally, and then appendix will be pulled into the cannula, and then without contaminating it should come out together with the cannula. So, this is the end of surgery. Now, thank you very much for watching this video. This was just a simple case of appendectomy, ovarian drilling and cholecystectomy. Thank you very much.